Gelfand. I'm a neurologist, which is a doctor that takes care of people with problems in the nervous system. So that includes the brain, the spinal cord, peripheral nerves, and everything that's in between. Here's where I come from. It looks a lot like Seattle, and what a beautiful weekend here today. So I'm going to start by talking about how a neurologist thinks. It's often said, based on studies where we look back and interview people with sarcoidosis, that about 5 to 10, maybe up to 15% of people with sarcoidosis have neurosarcoidosis, neurological sarcoidosis. Another way of looking at that is most people with sarcoidosis fortunately don't. But when you talk with people with sarcoidosis, neurological complaints are relatively common. And we've done this in a very formal way through the sarcoidosis research program that my colleagues in pulmonary medicine run at UCSF, asking people, do you have complaints that are related to the nervous system, such as cognitive problems, thinking problems, slowness of thinking, fatigue, and those are much more common. But in our experience, and in the experience of others in neurology who've studied this, most people with those complaints don't have evidence of active neurosarcoidosis. So the real question in the field is, how do we distinguish between active neurosarcoidosis that we define as inflammation of the nervous system, of this granulomatous type that we've been talking about all morning, versus neurological complaints that are real, they're bothersome, they're common, but aren't clearly from active inflammation, and what can we do to best treat that? So I'm going to talk about how we think through that today. So it's always important when you think through a medical discussion like this, how doctors think. And on one hand, there's a way that doctors tend to think generally, and then there's a way that even different kinds of doctors tend to think. And in neurology, we're taught to think by localization. And what that means is that when I see a patient for a neurological problem, whether sarcoidosis related or otherwise, I try to take a really good history. And it's often said that in the story is where the answer is going to be. And if you take a good enough history, which is an art, and sometimes requires really going back and taking even more details, usually the answer's there in the history. And we can use the story to try to start imagining where in the nervous system the problem could be coming from. And then what we do is we use physical examination, the actual exam, where we check things out in terms of how the eyes move, how the arms and legs move, coordination, sensation, walking, and try to then localize where in the nervous system, where anatomically the problem is. And then we say, what could be causing that? So as an example, if someone comes in and says, my legs are heavy, I take a very detailed history, and then based on some of the answers, I might be thinking, this is really concerning for a problem in the spinal cord. Then I do an examination, and I'll look and see whether that pans out, and make sure it's not other things in the peripheral nerves, etc. Then I might do some blood tests or some imaging to then confirm it. And then we go through a list in our head saying what in the spinal cord could cause that. Now it's important to not go backwards. And this is sort of the message here, is that when people come in saying, I have sarcoidosis, often it's, well, neurosarcoidosis can cause this, so thus this must be sarcoid. And I think that that's not the way you want to encourage your doctors to do this. You want to say, what is the cause of my neurologic problem? And then say, is it relevant that I have sarcoidosis? And then try to figure out, could that be the problem? So when I think through this, if I'm seeing a patient with known sarcoidosis for a neurological problem, there's really 4 possibilities. One is that they have another diagnosis. People are allowed to have more than one diagnosis. And we joke about that, but in medicine, we're often taught to try to link things together. And to say, well, we know sarcoid can cause this, and this, thus the final answer is sarcoidosis. But in real life, someone can have sarcoidosis plus, an injured foot from something else, right? Or sarcoidosis and migraine headaches. And we need to understand that not everything necessarily has to be sarcoid. And this is important because if we call something neurosarcoidosis, then that often dictates treatment. Whereas if we also miscall something else, for example, if the final answer is migraine, I have wonderful treatments that are evidence-based for migraine that aren't based on inflammation, and we should be offering that. possibility is that it could be what I was talking about earlier, neurological symptoms that are common in people with sarcoid, but who don't have evidence of active neurosarcoidosis. Or it could be neurosarcoid or treatment related. And so the key question I would ask you and ask your doctors is to say, okay, I understand that you're thinking that you're worried that this might be neurosarcoidosis, but let's pretend that I didn't have sarcoidosis. What else would you be thinking? And that's just a healthy exercise. So when we talk about neurosarcoidosis, there's lots of different ways of grouping it, but I think one way that's really emerging in neurology is this concept of how confident we are. And as my colleagues in ophthalmology were describing earlier, you can't biopsy everything. And in the nervous system, we can't biopsy everything either. And we often have to make circumstantial cases. So if someone has a neurological problem that looks for all the world like neurosarcoidosis, I will often try to find evidence of sarcoidosis outside the nervous system to try to prove the point if I don't want to go after a biopsy of the nervous system. And sometimes we can prove that, sometimes we can't. And if we can't prove it, I would call that possible neurosarcoidosis. And the reason to put a big possible there is just to remind ourselves that there's other possibilities. We haven't proven it. So if someone isn't responding to treatment the way that I would hope, it's a big red flag for every other doctor along the way too to say, we thought this was a good idea, it was a good formulation, but it may not be the final answer. Keep an open mind. Now let's say that someone has a nervous system problem that looks for all the world like neurosarcoidosis. Let's use an example of a meningitis or a spine problem, where again, I don't want to go after the nervous system if we have a better option. And then I might do an image of the chest. Let's say we find classic for sarcoidosis. We go through the diagnostics and prove the point and say, there's a diagnosis of pulmonary sarcoidosis. We will then say, given after good neurological evaluation and exclusion of infection and other mimics, meaning things that can look like neurosarcoidosis, we then call that probable neurosarcoidosis, meaning you have sarcoidosis and it looks for all the world like neurosarcoid, but we haven't biopsied it in the nervous system. And for many of my patients, that's as far as we ever want to take it. That's a pretty rock solid, strong diagnosis, but I still label it as probable just because we haven't biopsied the nervous system. And it's always healthy to have a signal of how confident we are. Sometimes we do biopsy the nervous system to really be as secure as possible. And if that is the answer, and after we've excluded other things, we call that definite or highly probable neurosarcoidosis. And then there are other neurological symptoms and syndromes that are common. One example being small fiber neuropathy, which can cause the small fibers are the microscopic fibers. They aren't myelinated. We can't use electrophysiology, these nerve conduction tests, to measure them. So they're really microscopic. But when they get injured, they can cause pain syndromes in particular. And they're common in sarcoidosis, but it's not clear that it's from active inflammation of the small fiber nerves rather than some other toxic injury from inflammation. So we call that paraneurosarcoidosis or a parasarcoidosis problem, meaning it's real, it's common, but it's not synonymous with neurosarcoidosis. And I think the terms matter here because what ends up happening is someone gets a diagnosis of neurosarcoid, and then you either Google it or in our world you PubMed it, you look for data, and then say, oh, the treatment for neurosarcoid is X. But the treatment for small fiber neuropathy is going to be very different than the treatment for brain inflammation. And that's where this level of detail matters. So let me give you a couple examples of what things can look like in the nervous system. So the granuloma is a big ball of inflammation, and it's a very unique calling card of inflammation. And this is one of the hallmarks of sarcoidosis really everywhere in the body, including the nervous system. This, thank you for, can we turn the lights down there? Perfect, and I will do the same with turning the lights down. This is what's called a brain MRI, it's a brain scan. And for those that are used to looking at MRIs, I think it's healthy to just sort of step back and think of how amazing it is that we can see the brain in this level of resolution so easily now, using a technique that's magnet-based, it's not radiation, and actually be able to look directly in and see brain structure in this way, and how really powerful that is diagnostically. What is going on here, let me just get the pointer, there we go, are these white dots all around here shouldn't be there. That's leakage of dye through a blood-brain barrier. We call that contrast enhancement, and that is typically interpreted as active inflammation. And to a neurologist, this is not subtle at all. This should be like this, where it's sort of a paper white line, and you have all these white spots all the way through. And when we do a biopsy, what you see in sarcoidosis is the granulomatous inflammation. And this is what a granuloma looks like in the covering around the brain. And what you see here is it's a big ball of inflammation. Most of these are what's called macrophages, so it's a particular cell type. And it's a really organized pattern of inflammation. We can do even other tests to prove that we're looking at the right thing. We want to make sure that it's not a fungus. We want to make sure it's not tuberculosis. If I showed this exact same brain scan and told the story that this is someone who just had a history where they could have been exposed to tuberculosis and had a fever and weight loss and all these things, this brain scan could look for all the world like tuberculosis. It's really through proper investigation that we say this is sarcoidosis. So this is what active brain inflammation from sarcoidosis looks like in one formulation. And this is really sort of the severe end of the scale. And this is what's called a meningitis. Now, neurosarcoid is often said that it can do anything. And that's not that helpful nor that accurate in clinical practice. It tends to do many things commonly and tends not to do other things. So when you Google this again, the problem is the list of symptoms that neurosarcoidosis can cause really encompasses all of neurology. And that's really just a function of saying if the inflammation happens to involve that part of the nervous system, it can cause weakness in this area or numbness in that area. But in practice, what ends up happening is it tends to cause a few different syndromes, such as affecting the optic nerve or causing a meningitis, affecting what's called cranial nerves. It can affect the spinal cord, or it can have particular looks in the central nervous system. And this is where it can be helpful to really get a proper neurologic evaluation if there's something neurological going on, to say, is this plausibly related to sarcoidosis? Now, this is the central nervous system. In the peripheral nervous system, sarcoidosis can cause what's called large or small fiber neuropathies. Neuropathy, so if you think of the nervous system, we have our brain and spinal cord, and then we send out wires to the rest of the body, and that's called the nerves, the peripheral nerves. And injury to the peripheral nerves is called a neuropathy. Apathy means just something not working right. And itis means inflammation. So if we have a neuritis, that's inflammation, but if it's a neuropathy, it just means the nerve's not working right. And we don't know if it's inflammatory or not. Now, there are many causes of neuropathy. By far, the number one in America right now is diabetic neuropathy related to type 1 and type 2 diabetes. There are vitamin deficiencies that can cause neuropathy. Sometimes alcohol can cause neuropathies. Sometimes medicines can cause neuropathies. So in someone with sarcoidosis who has a neuropathy, we again don't want to just say, oh, sarcoidosis does this. We want to do a proper evaluation to say, do you have a neuropathy from sarcoidosis, or do you have a neuropathy from one of these other many causes that can cause neuropathy? So this concept of a differential diagnosis, meaning a list of possibilities that we then rank based on plausibility and likelihood and seriousness, is broad. And sometimes for large fiber neuropathies, the kinds of neuropathies that we can measure with electrophysiology, a biopsy may actually be needed to distinguish sarcoidosis from one of the many causes. And this again is where expert neurological help can be very helpful. On the other hand, small fiber neuropathies are, again, the microscopic nerves. They aren't myelinated. When we do an EMG nerve conduction study in someone with a small fiber neuropathy, by definition, it's normal because we can't measure small fibers. But we can do skin biopsies, interestingly enough, sometimes to prove the point, because we can actually see the nerve endings, the small fiber nerves, in the skin. And with special stains, we can actually count and say, is it a normal amount? Now, there's only a few places where we have the normals to actually know whether it's too much or too little. And so, for example, we can do a skin biopsy on the top of the foot, but we don't do it on the bottom of the foot. It also just doesn't heal as well. So, a negative biopsy, if you're not going after the place that's hurting, may not be able to disprove it, but it can be helpful to prove that it's there. Often, though, in neurology, we can just take a really good history. He was talking about the story again, and say if someone has, painful burning sensations in their feet that are quite prominent and aren't going away, and we do a good exam and make sure there isn't a large fiber component, then we say that's almost surely a small fiber neuropathy, and we don't have to take it to biopsy. You can also do some special autonomic tests at certain centers around the country, and also spare biopsy. Small fiber neuropathy was said in one paper in The Lancet, one of the big medical journals in the world in the early 2000s, that up to 30-something%, depending on how you do your denominator, of people with sarcoidosis have some evidence of small fiber neuropathy if you go looking. That's quite high. I'm not sure it's that high depending on which subgroup and in this day and age with the treatments that we're doing, but it's high enough that if people have symptoms of this kind of syndrome, it's worth a proper evaluation. A couple observations just about how central nervous system sarcoidosis tends to spread and tends to look. It tends to infiltrate, meaning to be very local and to spread locally. And that's very different from many other inflammatory diseases. One analogy or comparison might be multiple sclerosis, where someone can have inflammation, say, of the optic nerve, and then later one of the spinal cord, and it tends not to be based on local spread. Whereas in neurosarcoidosis, often, not always, but often, there is inflammation in the nervous system that then tends to spread in that same pattern. It often involves that outer covering of the brain, the meninges. When that happens in sarcoidosis, we call that a meningitis component. But it's a very different meningitis than the kind of infectious meningitis that we're all very terrified of appropriately when we think of scary bacterial meningitis. This tends to be much more of a smoldering, slower moving type of syndrome where often people look a lot better than their MRI scans. And it causes a clinical syndrome that reflects the underlying neuroanatomy, meaning if you have inflammation in your spinal cord, the symptoms will be from the spinal cord. If you have inflammation in the eye, or in the optic nerve, the syndrome will be one of vision change or vision loss. So it's not so much that sarcoid can cause numbness, it's sarcoid can cause inflammation of parts of the nervous system that are involved in sensation. And that's the way we need to address this problem. Just as an example, this is a person with sarcoidosis who has evidence of inflammation that progressed on and off. This is again that leakage of the dye. And you can see it. These are the same anatomical cuts at different scans over the years. And the inflammation sort of waxes and wanes for years, which is striking. There's just very few things in the nervous system where you can have this kind of inflammation be persistent over a period of years. And on one hand, you'll have response to certain therapies, but at the same time, not necessarily come and go. And so when I see this kind of pattern, even early on, that's one clue that we can be looking at sarcoidosis. So we talked about the neuroanatomy. I've shown you examples that the MRI can be particularly helpful in terms of identifying active neurosarcoidosis. In particular, this contrast enhancement being a sign of active inflammation. Now, sometimes your doctor may not actually order an MRI with contrast, sometimes for good reason because of safety with the kidneys, but sometimes just because it may not be on the radar as much. And I think this is one where if this is the real active question, is there active brain inflammation, the contrast scan can be particularly helpful. In my world, if there's active neurosarcoid, active brain inflammation, I want that enhancement. I want that inflammation to go away. It's sort of analogous to the eye, where if you have uveitis, if you have eye inflammation that's causing problems, we want that to go away. Stable brain inflammation, if it's still there, isn't necessarily a good thing. And so the other thing when we're looking at MRI scans is to make sure that when we see the word stable, I want it to be stable good, as in it's gone, not stable bad here, right? So here the danger would be if you look at a brain scan right here, the report might be stable inflammation, but that might not be our treatment goal. So here's just an example of what sarcoidosis can look like, and these are all different examples here. So this is one causing an optic nerve type problem, and the message here is that even though it's affecting different parts of the nervous system, it tends to look more similar than different to a trained eye. And that's this kind of enhancement right here with this lumpy, bumpy pattern of enhancement that tends to look very typical of sarcoidosis and less typical of other brain inflammations that we see. In the pituitary, which is an organ in the nervous system that secretes hormones, it's really a master regulator of the endocrine system, you can get inflammation. And here again, it tends to look similar to the kind that we see elsewhere in the nervous system. And even in the spinal cord, we can see this kind of what we would call a very granulomatous pattern of inflammation that we see. Now, we've had a lot of breakthroughs in terms of treatment. I'm not going to spend too much time speaking about treatment here, but I'm happy to in the question and answer period. But in general, we start with steroids, and then we go to steroid-sparing immune suppression. And one of the big breakthroughs in central nervous system sarcoidosis has been the use of infliximab, a TNF-alpha inhibitor. And here's just an example of a patient of mine where there was 6 years of uncontrolled inflammation, not for lack of trying. We tried all sorts of big-time immune suppression, and it wasn't until treatment with a TNF-alpha inhibitor that we were able to achieve remission and keep remission now going for several years. There are several examples of this within the central nervous system. It's not controlled trials. These are all series and what we call case series. But we, as a neurosarcoidosis community, we've been working together to collaborate on research and share research data to try to get this experience out there. And this has been, there'll be papers forthcoming on this, but really the experience that we're seeing is quite similar to what other centers are seeing around the country, which is many, but not all people respond quite well to infliximab when there's active brain inflammation. We talked about the neurologic symptoms in people with sarcoid that are common. Again, when we poll people with sarcoidosis, about 20 to 30% of people will tell us yes if I ask, do you have problems with concentration or mild memory problems, word finding, headache. One of the things we're finding is that when we actually take a really good headache history, many of these headaches are actually migraine. And if we could properly diagnose them, we would help a lot more people. Pain is absolutely a problem, some of it being neuropathic, meaning nerve-based, some not. And then fatigue, which may actually come from the central nervous system, or at least manifests that way. This is a hot area, an important area of research within the sarcoidosis community. We often cannot put a single answer on any one person's complaints. For example, if we do a brain scan and it's normal, we may or may not elect to proceed with a spinal fluid examination, but in this context, if the brain MRI is normal and the exam's normal and history doesn't suggest something, the spinal fluid is usually normal. And we may not be able to pinpoint the exact cause. You might say, well, if sarcoid is better controlled, maybe these symptoms go away, but the data sets don't always support that. Whether it's cytokine driven, meaning inflammation driven, whether it's a medication issue, whether it's sleep related, whether it's pain related, is sometimes there a depression component? Is there sometimes some other vitamin or other environmental or dietary component? There's often in real life what's called multifactorial, meaning lots of little things or different things contributing to this. And so this is where a comprehensive, really whole person type approach to addressing these symptoms can be most beneficial. I think the key message though is that we as a community need to do better trying to understand the biology of this. At the same time, it's also important to acknowledge that these symptoms without evidence of active neurosarcoidosis shouldn't be synonymous with neurosarcoidosis. And for example, I wouldn't treat fatigue, for example, in isolation with an escalation of immune suppression from a neurologic standpoint without really evidence that it could help that way. So that's where names matter here. One final thing, and then I will stop, is that when we do spinal fluid exams, this can be particularly helpful to look for inflammation. And there's no one calling card of inflammation that says sarcoidosis. When we do a spinal fluid exam, it's sort of two reasons. This is to look for central nervous system inflammation. So it might be that there's an abnormal brain MRI, and we need to try to get more clues to understand how to interpret it. Sometimes people may have symptoms. An example might be a headache that just isn't going away, or there may be other concerning features. We do an MRI, and it may be, we can't tell, or it may be normal. And sometimes we will do a spinal fluid exam to make sure we aren't missing something, because MRI is very good, but it's not perfect. When we look, we want to make sure that it doesn't look like an infection. We want to make sure that there's no evidence of a malignancy. And from an infectious standpoint, one of the big research advances in the past year to a couple of years has been this use of genetics, not to just look at our human genomes, but to look at non-human material in there. And the spinal fluid, the nervous system, is really one of the first examples where this has been groundbreaking, and I think it's actually been illuminating for sarcoidosis as well. So this is a research-based pipeline that we have at UCSF. This recently became a clinical test as of July 1 through UCSF, so a real exciting advance that way. And what we do is if we take a tissue sample, in this case spinal fluid, we run it through the same machines that do genetic sequencing when we do human genetics. But in this case, we get rid of all the human stuff when we say, is there anything non-human in there that shouldn't be there? And spinal fluid is usually pretty sterile. And so when you find things in there that shouldn't be there, that could mean something. And the real art is the bioinformatics, where what we do is we use a lot of very good databases and controls to say, is there something in there that shouldn't be there? And just some examples, this was in the New England Journal, led by one of my colleagues a couple of years ago, where there was a young boy, and they even put his picture on the front page of the New York Times after this was published as a success story, who was dying of a meningitis that the doctors, despite their best efforts, couldn't explain. And this was a circumstance where there was a question of, is it infection or is it autoimmunity? And sarcoidosis was raised as one of the questions. And unfortunately, despite all sorts of antibiotics and really the best that we could offer medically, continued to worsen. And then said, maybe if it's autoimmune or sarcoid, we try steroids, worsened even more. They sent FedEx one of these spinal fluid samples over. The team that my colleagues ran mobilized, and within 48 hours they were able to find an unusual bacteria called leptospirosis as the cause, and then pinpoint the proper antibiotics. And with the proper antibiotics, was able to be cured. And the picture on the front page of the New York Times was him sitting on his front yard swing, looking like a normal 12-year-old boy. And so this was the reason it made the New York Times and the New England Journal. It's the first example of using this new technology to really change care quickly in a meaningful way, and sort of as a sign of where the future is going. And as I mentioned, we now do this as a clinical test. We've done on a research basis, looked at several people with neurosarcoidosis, where to the best of our ability, my ability, we say this meets all our criteria. And to date, we have not found any infection in the spinal fluid of the people that we've been calling neurosarcoidosis, which really confirms that at least in this concept of probable and highly probable neurosarcoidosis, where the emerging concept is that it's really an inflammation and autoimmune syndrome, does seem to pan out. But this is super important when we're doing these evaluations, where we say, what's causing a meningitis? And rather than just saying, oh, it could be sarcoid, here we can take this really to the next level and say, let's look a little further and make sure we're not missing infection. Now, when the spinal fluid's normal, this is not the time when we're finding infection. When people are looking good, this is not the time to go get spinal taps. This test really serves when we're doing active evaluations for things that could be active brain infections. But it's a message of the power of research and the power of trying to apply that, in this case, something from an infectious world to, I think, questions that really matter to us in the autoimmune world. And so I think that we'll be seeing a lot more of this down the road. I will stop there. Thank you so much.